My name is O'Dea. I'm a breast medical oncologist at the University of Kansas Cancer Center. For our early stage patients that have triple negative breast cancer, we've really seen some advancements in the past few months. The approval um, of pembrolizumab based on the KEYNOTE-522 data, very, very encouraging. You know, of course, in this trial, patients that received neoadjuvant chemotherapy were randomized to receive either chemotherapy with or without pembrolizumab. And we saw, of course, a much higher rate of pathologic complete response in the group of patients that received the neoadjuvant pembrolizumab in combination with their chemotherapy. Interestingly, if you look at the patients that did achieve a pathologic complete response, they didn't seem to derive as much benefit from the adjuvant pembrolizumab or immunotherapy. But if you looked at the patients that did not achieve a pathologic complete response, they definitely had a significant benefit from the adjuvant pembrolizumab, suggesting that, again, pathologic complete response, as we've sort of traditionally thought, is a very accurate predictor of prognosis. And it informs our decisions about, what kinds of therapeutic options we need to be pursuing for patients in the adjuvant setting. So I think it remains to be seen if every patient that receives neoadjuvant pembrolizumab, for example, that achieves a pathologic complete response, do all of them need to receive adjuvant pembrolizumab? That's a question that I think, we don't know at this time. Of course, based on the 522 data, we will give those patients adjuvant pembrolizumab, but at this time, it's not clear, and that's a potential opportunity for future sort of de-escalation of therapy. It also raises a question for us about how do we approach these patients that do not achieve a pathologic complete response, understanding that we have data currently based on the CREATE-X trial for adjuvant capecitabine that showed a survival advantage for patients with triple negative breast cancer not achieving a pathologic complete response for 6 to 8 cycles of adjuvant capecitabine. So how do we sort of put that in line with the 522 data, and how will we prioritize those sorts of things for patients? These are going to be clinical challenges that we are faced with daily in our clinics. For myself personally, I'm looking at each patient and looking at how they tolerated their neoadjuvant therapy. Did they receive neoadjuvant immunotherapy? If they did, then I'm definitely giving those patients the adjuvant pembrolizumab. We also look forward to future trial results. For example, there was a SWOG trial looking at adjuvant pembrolizumab for patients who had residual disease after neoadjuvant chemotherapy. In that trial, patients had to have at least 1 centimeter of residual disease, and it did have to be PD-L1 positive. In the KEYNOTE-522 trial, as you know, that was regardless of PD-L1 status. So just patients with triple negative breast cancer, regardless of PD-L1 status, seem to derive a benefit from the neoadjuvant and adjuvant immunotherapy. So again, a lot of important advancements, but also sort of raising a lot of questions. With everything we learn, of course, we learn 10 things that we still need to learn. And that's going to continue to be questions that will be answered with some of the trials that are currently underway and have been completed. But right now, again, very excited about the KEYNOTE-522 results and understanding that the incorporation of neoadjuvant and adjuvant immunotherapy for those patients with triple negative breast cancer is definitely improving outcomes for those women.